Thank you, Kevin. So thank you very much, Kevin and Daria, and to Spark for having me come speak to you guys today. I'm going to be, as Kevin just mentioned, telling you about a drug we're trying to develop to prevent autoimmunity. My collaborators on this project are my wife, Jenna Bollyky, who was an endocrine fellow when we started this, and then Adam Frymoyer, who's over there in the back, who's a clinical pharmacologist. The other people on this slide, you may have noticed, are Charles Darwin and Ann Landers. And they're here to help me make, or to remind me to make 2 points. The first one is about evolution and adaptation. I think as scientists, as academicians, we're quite good at problem solving, or we try to be. And one thing that doesn't necessarily come as intuitively is adapting to the marketplace. And so I think maybe perhaps in the same way that the theory of evolution sort of changes the way we look at biology, I think one function of partnering with Spark and the marketplace has made me think very differently about the science I do and what I'm trying to achieve as a physician scientist and to adapt to the needs of what's actually involved in bringing something to the market. Ann Landers, on the other hand, is there for me to point out that while Spark contributes resources and other advantages, I actually think that the main thing that I got from Spark, or that I get from Spark, is actually advice. And you know, it's you guys in the audience, many of you advisors, but then also direction and sort of well-timed guidance that's made the difference for our project. And I'll come back to these themes as we go along. So type 1 diabetes is an autoimmune disease. It involves the destruction of the pancreatic islets that ordinarily produce insulin. It's different from type 2 diabetes, which is associated with being obese and requiring insulin as well, but not necessarily immediately losing your beta cells. But type 1 diabetes tends to be a disease of children and young adolescents, and it results in a critical requirement for insulin. And when we were looking at cadaveric tissues from individuals who died of type 1 diabetes versus controls, what we found is that the type 1 diabetics, their islets had this molecule called hyaluronic acid, which is a component of the extracellular matrix associated with chronic inflammation. And we noticed this deposition of hyaluronin in recent onset type 1 diabetic individuals. We saw the same thing when we looked in mouse models of type 1 diabetes, specifically the Dormo mouse and the NOD. And after seeing this, we wondered, well, if we stop the production of hyaluronic acid, can we stop diabetes? Does it contribute to the pathogenesis of the disease? And fortunately for us, a paper was published a few years ago that did I guess the authors did a screen of different compounds and found one that was already an existing drug that had this interesting side property of turning off hyaluronic acid production. The drug is called hymecromone, or cantabilane here, and what it's used for is to prevent gallbladder spasm. And this property of turning off hyaluronin isn't anything anyone knew of. The interesting thing is that it's been a drug for about 40 or 50 years. It has a very well-defined mechanism of action, and it's incredibly well tolerated. In those 40 or 50 years, the side effect profile is really minimal, maybe some diarrhea and nausea, which you would expect with a drug that affects bile synthesis. And it inhibits a pathway that's involved in making hyaluronin as well as in biliary spasm. And so we thought of hyaluronin as a novel therapeutic target in autoimmunity, and this drug maybe is something we could repurpose to prevent this disease for which currently there's no cure or preventative treatment. And so what we found is when we gave this drug to our mice, indeed, it did turn off hyaluronic acid production, but the neater thing is that it actually prevented diabetes. So we could keep animals that would otherwise develop this disease on the drug for up to a year, and they would stay blissfully diabetes-free. We've since put this into other models of autoimmunity, a model of MS in particular, and it does the same thing. And it's interesting, hyaluronin ends up being, we think, what puts the white and white matter lesions in MS, in that's T2 weighted highlighting on MRI, which is basically moving water around, which is what hyaluronan does at sites of inflammation. Similarly, in Graves' disease, the proptosis that people get with their eyes popping out, looking hyperthyroidistic, is basically hyaluronan, which infiltrates that musculature. So we think that this is sort of a keystone molecule at sites of autoimmunity, and our data here suggests that if we inhibit it, we can prevent disease. So can we use this in people? And it turns out that the drug actually has some unfortunate PK hurdles. It has a large first-pass metabolism and a short half-life. And so what we used our funding from SPARK from initially was to look to see whether or not this would still work in mice at the doses that we would give it to in people. And the short answer is no, right? And so this is basically where the evolution and adaptation comes in. So Kevin suggested, well, you know, why not essentially adapt and use your drug, which gets into the bile really well, to treat an autoimmune disease of the biliary tract. And it turns out that primary sclerosing cholangitis is a terrible disease that involves the fibrosis of your biliary tract and ultimately leads to a necessity for transplantation, pretty much in all the folks with this disease. And there, not unlike type 1 diabetes, are no cures. And so this is actually quite cool, and it's also associated with deposition of hyaluronan, because it affords us an opportunity, if we could just adapt the way that we're thinking, to treat an autoimmune disease with this established drug that actually reaches quite high concentrations in the bile and in the liver. And so what SPARK did for us is they found us someone to help us write an IND. They found us a private donor who was willing to give us some funding for this, and then they gave us some SPARK money as well, and we've since submitted the documentation. The FDA has reviewed this. We're in the process of responding to their comments, and hopefully we're going to be starting treating patients with primary sclerosing cholangitis shortly. I should also mention that they introduced us to Ken Cox, who's a physician here at Stanford who works on this disease. And so really, they're sort of the Tetris piece that's kind of connected all these other bits into this wall that we're trying to make to stop this disease. So very exciting. The other thing that they helped us do, getting back to Ann Landers, is advice. And so they introduced us to medicinal chemists, people like Robert Lum, I don't know if he's here in the audience, but Jay Rajadas and some others, who helped us make a panel of 4MU prodrugs. And we've since validated these and identified a few that seem to inhibit hyaluronan synthesis in people. So potentially now we've got a new plan B to take this drug and target this pathway to treat type 1 diabetes and other diseases. So what are the next steps here? I should actually, just to stop and sort of point out, maybe, I don't know if it's a victory lap, but a thank you to Kevin and Daria. So this has resulted in 5 or 6 papers, which has a scientist I care about. We have 2 patents, one on 4MU itself, one on the new compounds that's just gone in. And then we have NIH funding to develop this pathway and figure out exactly how this works, which is quite cool. So the next steps, what's this? And an IND. And an IND. So the next steps are to take this into the clinical trial and see whether or not it works in people. If it does, specifically, we're going to be looking for decreased amounts of hyaluronan. And I didn't mention this when I was talking about the mechanism of action, but this drug induces FOXP3 positive Tregs through a CD44 dependent mechanism, which is the receptor for hyaluronan. And so what we're going to be doing is looking to see not only can we stop PSC, but can we diminish hyaluronan? Can we induce FOXP3 positive Tregs? And if so, that gives us the momentum to really develop this and take this into other diseases as well. And so now we're at the sort of fork in the road where we're trying to figure out, do we license this? Do we start a company? What else do we do? And this is the other place where SPARK has been tremendously helpful in terms of introducing us to folks who can help set this up and to lawyers. And I imagine that we'll be benefiting from their help in the future as we bring this forward to the next steps. So finally, before I sign off here and let everybody go get coffee, I just want to make sure that I thank Kevin and Daria, because the other part of this I think that's worth commenting on that hasn't been mentioned yet is, from my perspective, the role modeling that they do and the facilitating. The combination of passion and perspective in terms of the research that they're prioritizing. You've heard a lot about repurposing. You've heard a lot about rare diseases, things that wouldn't necessarily get off the ground, without a little bit of push, I think is tremendous. And then the last thing is modeling collaboration. Because I do feel like, this is a terrific example of maybe, in my limited experience, what academic business partnerships can do and how these things can work well and how we can all work well together. And that, obviously starts from the top and it starts with them. So thank you very much, and a particular thanks to the two of you guys, and I'll take any questions.
Class switch anti-cancer therapy with PD-1 antibody sometimes cause autoimmune disease. So autoimmune disease and cancer are both sides of one coin. So if you reduce the autoimmune disease, then you may have the possibility to increase cancer or promote cancer. How do you think about that?
Well, it's obviously something you worry about. In our mice, and we've had them on this drug for over a year in different studies. They didn't develop any. And one of the nice things about this being a 40 or 50-year-old drug is we have lots of records from the EMA, and in that time you don't have any cancer complications. That being said, it's not totally clear to me what the systemic dose of the drug is, which is why we're trying to develop our prodrugs. So it's possible that could become a concern. But that, I think, just highlights the need to really develop drugs like this and some of the other ones you've heard about, rigorously and with a lot of proper vetting.
Thank you.
Okay.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.